Knee is a remarkable joint designed to handle significant mechanical stress during everyday activities like walking, running, and jumping. However, when the alignment of the lower limb is altered, such as in varus deformity, the forces across the knee become unbalanced. This misalignment, where the leg bows outward, leads to increased pressure on the medial compartment of the knee. Over time, this abnormal loading can cause or worsen cartilage and meniscus injuries, resulting in pain and limited function. Fortunately, surgical techniques like high tibial osteotomy (HTO) have been developed to correct this alignment and relieve symptoms. HTO is especially effective for patients with medial compartment osteoarthritis or damage, providing a way to preserve the joint and delay or avoid the need for knee replacement. In this video, we'll explore how HTO works, who it's for, and what outcomes patients can expect. Precise preoperative planning is essential for a successful high tibial osteotomy. Surgeons carefully assess limb alignment using radiographs to determine the mechanical and anatomical axes of the femur and tibia. Key measurements such as the mechanical femorotibial angle and the medial proximal tibial angle help guide the correction needed. There are two main surgical techniques, the lateral closing wedge (LCW) and the medial opening wedge (MO). LCW involves removing a wedge of bone from the lateral side, allowing the leg to straighten as the gap closes. MO, on the other hand, creates a gap on the medial side, which is then opened and stabilized with a plate, sometimes using bone grafts. Each method has its advantages and considerations, and the choice depends on the patient's anatomy and the surgeon's expertise. Both techniques aim to shift the mechanical axis laterally, reducing stress on the damaged medial compartment. After high tibial osteotomy, patients typically begin with partial weight bearing for 2 weeks, gradually progressing to full weight bearing by 6 weeks. Return to recreational sports is often possible after 3 months, though this timeline may be adjusted if additional cartilage or meniscus procedures are performed. Both MO and LCW techniques have shown excellent long-term outcomes, with high rates of return to work in sports. Studies report that most patients experience significant pain relief and improved function, and many can delay or avoid knee replacement for years. However, as with any surgery, there are risks. The most common complications include hinge fractures, implant issues, and nerve injuries, though these are relatively rare with careful technique. Importantly, HTO preserves the native knee joint, allowing patients to remain active and, if needed, undergo knee replacement later in life with good results. Overall, HTO is a valuable option for young, active individuals with varus knee deformity and medial compartment problems.